hypertension clinic is just up the river from here, wending your way up the river, just in the shadow of the Shard here. The local population here from Southwark, the last census, 24% of the population reported their ethnicity as black African or black Caribbean, and the remainder mainly white British. And the black, to use a shorthand, were overrepresented in our hypertension clinic. So approximately 60% of our referrals to the hypertension clinic are black African, black Caribbean. That compares to a cardiac clinic I used to do, dealing mainly with ischemic heart disease, where less than 10% of the referrals from exactly the same GP practices were from black African, Caribbean subjects. So I think the relevance of ethnicity in this context is at least threefold, that ethnic group determines cardiovascular risk, then there are implications for individualising treatment, and perhaps most interestingly, it may provide us with some insight into etiology and targets for treatment. So in terms of risk, if one compares black, and by black I mean again black Caribbean, black African versus white, there's a greater prevalence of hypertension in this group. So for example, in the Whitehall 2 study, civil servants had a fourfold greater risk of being hypertensive if they were from the black compared to white group. And in Franco Capuccio's survey in South London, there was also increased prevalence of hypertension. There's greater hypertension-associated mortality, so roughly 3 times the national average, data from England and Wales. And that's mainly driven by stroke. An intriguing finding is, as Kennedy pointed out yesterday, that there's actually lower CHD mortality, which is estimated to be only 1/3 of the national average. Now, the situation in North America is slightly different. There are similar trends for greater prevalence of hypertension and stroke, but there CHD mortality is, if anything, higher. And one striking thing from North America really is the risk for progression to end-stage renal disease, which is 20-fold greater in black compared to white, and the leading cause of end-stage renal disease. So an important risk modifier. What about individualising treatment? Well, there have been a number of studies over the years which have shown that if one compares black to white, there are different responses to treatment. So this is a meta-analysis of some studies that were published quite early on, where the comparison was with placebo, and they were studied in groups including both white and black by the same definition. And what you see is that when comparing white response to blood pressure lowering response in white compared to black, then there's a less favourable response to diuretics and calcium channel blockers in white compared to black, and a slightly better response to beta blockers and ACE inhibitors. And I think the findings have been pretty consistent with a relatively large number of studies. The size of the difference has obviously varied, but qualitatively the findings are very, very similar. Now, in terms of outcome data, there's not a huge amount of outcome data because relatively few trials have included a sufficiently large number of subjects from different ethnic groups. But in ALLHAT, the relatively large number of black Americans, and there was a pre-specified subgroup analysis in black subjects comparing lisinopril to chlorthalidone, and what was seen here is that in black subjects they did less well when randomised to the lisinopril arm with respect to stroke. It's quite a striking difference, whereas there was no difference in outcome in the non-black subjects in this study. And then there was a retrospective subgroup analysis done comparing the response to amlodipine versus lisinopril in black and non-black subjects. And in black subjects, those that were randomised to lisinopril did less well than those randomised to amlodipine, whereas the non-black subjects, the outcomes were very similar. So that's ALLHAT. There have been a couple of other studies. The INVEST, which was calcium channel blocker based versus beta blocker, didn't show a difference between ethnic groups. In LIFE, the findings were really consistent with ALLHAT. So a suggestion from the outcome data that black subjects do less well on an ACE inhibitor or an ARB compared to a calcium channel blocker or a diuretic, and that could at least partly be explained by the blood pressure response, which, you know, in round terms, about 5/2 lower in those two studies. What about giving us an insight into etiology? Well, to do this, we really need to understand what features of ethnicity determine the blood pressure response, the blood pressure physiology. And obviously ethnicity wraps up a huge number of environmental and genetic factors. I'd just like to illustrate this with some results from a study that we did with Lale Calvert, Kings and Terence Forrester in Jamaica. And the idea was we would look at vascular function in the healthy population in southeast London and compare Caribbean subjects to white subjects and make a similar comparison between South London and Jamaica. And Cal managed to recruit some research fellows that were very keen on doing this study, because one of them got to go to Jamaica, the other one was Curtis Rambran, who stayed in the UK. So the idea was that by comparing the Caribbean to London, we would look primarily at an environmental difference, and the other comparisons, Caribbean in London and white in London, we would be looking at a gene-environment interaction, and similarly comparing white in London with Caribbean in the Caribbean. So if we look at the results, first of all, comparing Caribbean in the UK with white in the UK, so this is the comparison that's often done in looking at ethnic differences. Then we reproduce what's been reported before in terms of endothelial function, with worse endothelial function in the Caribbean in the UK compared to white in the UK, and increased intima media thickening. But when you do the comparison of the same ethnic group in the two different environments, you see what enormous effect that environment may have. So here we have Caribbean in the UK, much worse than Caribbean in the Caribbean. And then if you make the comparison between Caribbean in the Caribbean and white in the UK, you would get completely the opposite result. So what this really shows is an enormous impact, or potentially, of environment, and how difficult it is to disentangle the various features of ethnicity which may be contributing to these differences in risk and response to treatment. But if we stick to the same environment, the UK say, and look at differences, are there any differences in physiology that we can identify? Well, as you know, there are well-described differences in renal sodium homeostasis, so that in black subjects there is a tendency to sodium retention, suppressed plasma renin, and salt sensitivity, with blood pressure being very responsive to salt restriction. In terms of vascular physiology, as well described, impaired availability of endothelium-derived nitric oxide, which for people interested in endothelial function, they think is important. Exactly how important it is, possibly a little bit more questionable, but nevertheless very well described, and numerous other differences in physiology. So here's some science from Peter back in 1979, looking at renal profiles in actually the healthy population. So I think these were factory workers, and what's shown here is a shift to the left in the frequency distribution curve of renin, with a high proportion of the healthy black population having lower renin. And this has been reproduced in many studies, and we did a study recently and our results were almost superimposable. But what is very striking is that if we look in patients from our hypertension clinic, the difference is much greater. So this is the prevalence of low renin status, and at the time we did this study, what low renin status meant was renin below the limits of measurement of the assay. And so in our Black African, Black Caribbean population, it was about 60%, whereas less than 10% in white. And it didn't make much difference whether you were on treatment or untreated. And if you look at the size of the difference, this is black compared to white, levels of renin with people on various different treatments. It's approximately threefold, renin is approximately threefold higher. These are median values in white compared to black. And just one thing to point out from this slide, the presence of diuretic treatment, which is traditionally thought to increase renin, activate the renin-angiotensin system, doesn't make very much difference in the people with suppressed renin, whereas it makes much more difference in the people with a higher renin. So what could underlie this? Well, as you know, there's been a lot of speculation, and most authorities would suggest that it relates to some differences in renal tubular sodium reabsorption. And there are many potential candidates for this, and that's really sort of demonstrated by conditions like primary aldosteronism, Liddle's syndrome. But in a relatively recent review, Aviv and colleagues looked at all the available data, and from indirect observations, they suggested that the ethnic difference in renal tubular handling might lie in the thick ascending limb of the loop of Henle and the sodium-potassium transporter. Now, it's interesting to those of us interested in nitric oxide, because it's been shown that this transporter is under the influence of nitric oxide, so that nitric oxide inhibits it and produces a natriuresis. And Ken Connell, that is from Barbados and did a PhD with us, did some studies on this, looking at the potential relevance of this to the low renin phenotype. And what Ken did was to look at the effects of systemic inhibition of nitric oxide synthesis on renal sodium handling. Now, when you give a systemic inhibitor of nitric oxide synthase, it normally increases blood pressure by a few millimetres of mercury, and you would expect that to give a pressure natriuresis, but in fact it doesn't. It does the reverse, so that it reduces excretion of sodium, shown here as the fractional excretion of sodium. And the results are very dependent upon renin status, so that if you have a low renin, then there's almost no effect. Now, this is only observational data, but nevertheless it does suggest that there may be a link between these two aspects of vascular physiology and renal physiology, and it's a demonstration at least that this interaction is potentially important and could underlie some of the differences, at least, that we're seeing in renal physiology. And the important thing here in this study was that actually that the responses were best predicted by renin status rather than ethnicity. So can we use renin profiling to guide treatment? Now, I think this is a question that many people have been interested in, and Morris has a lot of data on this. But the question was addressed quite some time ago, actually, 1998, when there was a trial done where roughly 1,000 people with relatively mild hypertension were randomised to one a number of antihypertensive agents, and they had renin measured, and what the study did was to look at whether the response could be predicted by whether or not the treatment was correct or incorrect according to the Renin of the patients or according to their age and ethnicity. And the bottom line was that actually it didn't perform much better than predicting the response on the basis of age and ethnicity. However, there are a number of caveats here. There wasn't really a very large spread of Renin values, and so I think it really remains an open question as to whether in groups of subjects with a very wide spread of Renin values and a relatively large number of people with very low Renin, that doesn't increase even after diuretic therapy, whether or not Renin profiling would provide a guide to treatment. So to sum up then, a greater prevalence of hypertension associated mortality in black compared to white, lower CHD mortality, greater prevalence of low renin salt sensitive hypertension. There may be a common mechanism underlying differences in vascular and renal physiology, and that is most likely related to environmental rather than genetic causes, although I've got no proof of that. There's undoubtedly a better response to calcium channel blockers and diuretics compared to ACE inhibitors and angiotensin receptor blockers in black compared to white. The role of renin profiling still uncertain, but maybe holds some promise. So in terms of practical things, in terms of treating people, black Caribbean, black African, well then obviously low salt is incredibly important in this group. In terms of the first agent, then very reasonable to use a calcium channel blocker. After that, really, I think we run out of really hard evidence. Very reasonable to add an ACE inhibitor or possibly an ARB, particularly if there's any CKD, because these agents have been shown to be protective in both ethnic groups. Very reasonable to add a diuretic, and then when you get onto this sort of beetroot-coloured area here, you can do pretty much what you like, but I think a lot of people now are moving towards additional diuretic treatment. And again, I think we're going to learn something from pathway here, but not necessarily just in the black Caribbean, black African group. And indeed, you can. I quite like the idea of nitrates and hydralazine, which I use when in dire straits, because I have this prejudice that there may be a lack of nitric oxide, and similarly you can get people beetroot juice as well, but again, no evidence whatsoever as far as I know. What about the future? Well, I think that at the moment a lot of our evidence is based upon studies from North America, and I think we need to be a little bit cautious in extrapolating that data because of the differences that I've shown in the epidemiology. So there may be a case for randomised trials within ethnic groups in the UK. And then I think to make progress into gaining insight into what this epidemiology is telling us, we really need a better characterisation of ethnicity. So we have now ancestry informative genetic markers which will tell what proportion of our ancestors come from a particular geographical region. That may be helpful, but I think the real money really is in exploring the renal physiology in more detail. So I'd just like to end by acknowledging Andy Stewart and Ken Connell in particular, who taken the experimental data I presented, and also if I could just end also with an advert for the ARTERY meeting in October. Thank you very much.
Thanks. Thanks. I think we've got time for a couple of questions if people have got them. Wayne.
I'm probably going to reveal my ignorance. But I think I saw something from the States looking at people who'd emigrated from Southeast Asia to the States and showing that their characteristics began to mirror those of the population they'd gone into. But in the first generation, there was quite a few adverse risk factors. Have you looked at people that are born in this country versus those not? Clearly there's a generational difference in terms of...
Well, no, we haven't done those studies, but those studies have been done. I think that that's what they show, that as you spend more time in a Western society, it's exposed to more risk factors. But that probably doesn't explain the whole difference because of this... Yeah.
I'm suggesting that when you first come to a different environment, you're programmed wrong. So there's a gene programming.
Okay, yeah. 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 I mean, I guess these issues are very important, but I think that one of the fascinating things about these ethnic differences is the contrast between the CHD risk and the blood pressure associated mortality. So just exposure to risk factors probably doesn't explain that.
Okay. Maurice.
So, nice talk, Phil. The difference in Renin between Afro-Caribbeans and Caucasians is amazing, and there must be an explanation for it. And I was interested by what you showed, albeit of very different populations, the difference in the normals of Peter Sever and your hypertensives. I've always been struck by the fact that in the rare monogenic syndromes, where we know the molecular basis for lowering hypertension, aldosterone is suppressed, and the best example is the Gordon syndrome, where despite potassium being high, aldo is still low. And it seems to me that tells us that when the aldo is not suppressed, or even slightly higher, as you showed in your patients, the hypothesis must be that aldo is actually what's driving the low Renin hypertension. And I wonder whether quite a high proportion of the low Renin Afro-Caribbeans have small, what we now call zone glomerulosa-like aldo-producing adenomas. The question is how you go looking for them. But I just add that we have a theory and quite a lot of growing evidence that if you're accumulating salt, if you're exposed to excess salt, the zone glomerulosa, whose job is to respond to that, actually is given a selective advantage for making these small adrenal adenomas. So there's a potential vicious circle that in a population who genetically or environmentally hang on to salt, they're more, not less likely to have aldo-producing adenomas than other ethnic groups. And maybe this is the time to start looking.
Yeah, no, thanks very much, Maurice. I'm sure you're right. I mean, I think there is evidence that aldosterone is inappropriately high in this particular ethnic group, and that we up to now we haven't looked that hard. But perhaps, as you say, we should.
Phil, I think we should move on in the interest of time. But thank you very much.